So, and the thing is, I must say, ki today Dr. Saurav Dhanajasar is here. So when it was my final DRNB practical exam, Sir was there in the as a coordinator in the Gangadam hospital. So it's a kind of deja vu like situation for us. Getting back to that scene. Okay. So today's topic is stroke, specifically
This
ischemic
meeting is
CVA
being recorded.
we are dealing with. So it's a vast topic. We don't know how much we can cover within 1 hour or so. We'll start with the history first. So basically, it's a 67-year-old male, known hypertensive, also suffering from type 2 diabetes mellitus, was brought to emergency room with the complaints of weakness of the right side of the body for 2 hours. He woke up from sleep at 6 o'clock and was apparently normal. He noticed weakness of the right side of the body and face at 8 a.m., and which was remained constant.
Shanu, I think
Then,
your screens are not
he,
visible.
huh?
Your screen is not moving. The first slides. Is it moving to the candidates?
It's moving.
Now we can see the first slide. Now we are able to see.
You can put it on slideshow.
Yeah, I have already put on slideshow only.
Because the screens were not moving. Now the history scene has come after you clicked it.
Now it's being shared.
The first, yes, we can see.
This is better. This is best. Yeah. Yeah.
Okay.
Perfect.
What's happening with the sharing? It's being shared.
Yeah. We can see the history screen now.
Okay.
You can continue. Thanks.
So his current medications are tablet losartan 50 mg BD, tablet amlodipine 5 mg OD, and tablet metformin 500 mg BD with a tablet glimepiride 1 mg BD. It's moving now.
Yes, sir.
Okay. So come to the next part. In examination, he was drowsy but obeying commands. Beats per minute, though regular. Hypertension, blood pressure is 190 by 110, and saturation being 98% with room air. Central nervous system examination revealed slurring of speech, right facial palsy, right dense hemiplegia, power 1 by 5 in upper limb and 1 by 5 in lower limb, rest right, rest left powers is okay. Pain and touch sensation on the right side of the body were absent. Plantar reflex was upgoing and deep tendon reflexes were mute on the right side. Rest other reflexes are normal. The left side motor and sensory examination was normal, as I've said. So there is no history of loss of consciousness, seizure, vomiting, fall, fever, visual disturbances. ECG is normal. Random blood sugar is 186 mg per day. That's the history. So today's volunteer is Dr.
Grishma, sir.
Okay. So just from the history, try to find out the differential diagnosis and what are the history mode you want to take and what mode examination you want to proceed further. I'm
Okay,
just
sir.
talking about the examination, not into the investigations.
Okay, sir. So from the history, my differentials would be one would be acute stroke, which could be either hemorrhagic or ischemic in origin.
Okay.
Then hypertensive encephalopathy is a possibility, sir.
Okay.
And since he's having headache, migraine with aura is a possibility.
Okay.
Then we have to rule out Press syndrome also. Then we have to rule out any meningitis or encephalitis since he's having headache also. Then we have to rule out any space occupying lesions in the brain, like any neoplasms. We have to rule out. And we also have to rule out FAH since he's having complaints of headache. Even though it is not that severe, we have to rule out, sir.
Okay. Okay. So, what are the examination you will do for this patient? Specifically, always starts from the general examination, because during my examination also, my examiner have asked from the general examination, proceed to systemic examination, everything she have asked me.
Okay, sir.
So, in this case, what are the specific examination and what are the specific signs or negative history you will look for?
So, sir, I'll definitely assess a patient's neurological examination, including his higher mental functions and cranial nerve examination, motor, sensory, everything will be assessed, sir. His meningeal signs will be looked for to rule out clinical evidence of meningitis. Then, cerebral examination will also be looked for in the clinical examination, sir.
And all the reflexes, no?
Yes, sir. All the reflexes.
All the reflexes, superficial and deep.
Yes, sir.
Okay. Okay. Just go through the higher motor, how to examine higher motor function, how to examine each and every cranial nerves, and
Okay,
how
sir.
to examine the reflexes. At least, if you not do, at least you can tell.
Okay,
Okay.
sir. Okay.
Any other system examination you want to?
I'll definitely look for the cardiac examination, sir, because cardioembolic is also a possibility for this embolic stroke. I
Yeah.
want to rule out the cardiac examination. And as a routine part, I'll look for the respiratory and abdominal examination also, sir.
Okay. 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 And any other history you want to take from the patient?
Um, um, any um, any history of trauma, or if he's on any anticoagulants, and whether he had any previous episodes of stroke or recent head surgery. Um, um, like histories I need to ask, sir. Or if he already has any known case of neoplasms, brain tumor, I need to.
Any other medication history you want to take?
Uh, uh, Regarding anticoagulant use, I need to ask, sir.
Anticoagulant and antiplatelet you will definitely,
Yes, sir. Yes, sir.
but anything other than that?
Um,
Any psychiatric medication history you should take. Okay.
yeah, okay, sir. Okay.
Okay. And definitely about the insulin history.
Yes,
Okay.
sir.
Whether the patient is taking insulin.
Insulin.
Hypoglycemia can be a stroke mimic.
Yes, sir. It can be a stroke mimic. Yes, sir.
Yes. Yes. So,
Um, I like ask the drug history also, sir.
okay. So here is the differential diagnosis, and rather we will call this stroke mimics or ischemic stroke, hemorrhagic stroke, hypoglycemia. We'll discuss about ischemic stroke and hemorrhagic stroke, how to differentiate. We'll come to that part of later.
Okay,
So
sir.
hypoglycemia, here that's not a cause because the random blood sugar is 186.
186. Yes, sir.
Yeah. Then post-ictal paresis, you have said, Todd's
Yes,
paralysis, post seizure, we should take the history of seizure.
yes,
Then
sir.
neoplasm shouldn't happen this this acute manner. It will be a gradual thing. Sinus venous thrombosis, you should take care the history of any malignancy,
Yes, sir.
diabetes, neck trauma, dehydration, any
Okay,
estrogen containing pills and everything
okay, sir.
for
Okay,
the
okay, sir.
venous thrombosis to rule out.
Okay,
Multiple sclerosis would be a very gradual course.
okay,
Hypertensive encephalopathy will present as a, but the headache will be much more than this. Headache will be there. There might be a visual disturbances, and any other organ dysfunction can be present, and
okay,
hypertension will be definitely there. Then
okay, sir.
specifically hemiplegic migraine can present like this case. So we have to take a
Okay,
history of any migraine medication he is taking or not. Then
okay,
as you rightly enumerated the meningitis, vasculitis or brain abscess, all these having a basically triad of those things, altered
okay,
mental senses, altered mentation, headache and fever. These three things will be there. And then of
okay,
course I have told you hysteria and psychiatric illness.
okay,
Now,
sir.
now tell me, what are the differentiating features between hemorrhagic and ischemic stroke? How will you differentiate between these two?
Okay, sir. So usually, this ischemic stroke will be having a more gradual onset, whereas hemorrhagic stroke, they are usually more severe in presentation. And in hemorrhagic stroke, there will be often a history of severe headache, vomiting, and there will be faster deterioration of the neurological deficit compared to ischemic stroke. Sir.
Okay. Anything more?
Um, Sir, I'm not sure. I know only this much, sir.
Okay. So basically, ischemic stroke there will be absence of onset headache and vomiting. Whenever a stroke present without headache and vomiting on the onset, it's definitely going for ischemic stroke.
Okay, sir.
But have you told that there is ischemic stroke, there is a rapid onset and offset of symptoms. Okay, contrary to your belief.
Okay.
There is presence of cardiovascular diseases such as chronic hypertension, recent myocardial infarction, atrial fibrillation, valvular heart disease, and peripheral vascular disease. And you can get murmur, carotid bruit, or atrial fibrillation. And the features favor of hemorrhagic strokes are onset headache and vomiting, as you told, especially in case of subarachnoid hemorrhage. There is absence of neurological deficit at onset. Okay, it will come later. It will be gradually progressing.
Okay, sir.
Altered mental status and seizures are more common in case of hemorrhagic stroke. So a patient can presented with a hemorrhagic stroke with seizure, then both seizure related to paralysis and the stroke related paralysis. Okay.
Okay, sir.
We just don't rule out if a patient presented with a seizure and then hemiplegia, don't rule out the chances of hemorrhagic stroke.
Okay, sir.
Progression of neurological deficit over few hours and absence of early improvement and severe uncontrolled hypertension, and the cocaine use can be there. That's not very common in India, but it can be there. Okay.
Okay, sir.
Now just tell me, how will you assess this kind of patient in a pre-hospital setting? Is there any score or anything you know of?
Yes, there are several scales like BFAST scale, Cincinnati pre-hospital stroke scale, then Rosier scale, and also Los Angeles pre-hospital stroke screen, sir.
Yes, you have all told all the thing. See, just remember, only FAST is AHA and American Stroke Association recommended stroke. All the CPSS and Los Angeles pre-hospital stroke scale are not recommended by the AHA or But remember, FAST is not very accurate. It's a very, I'll say, it's just a preliminary tool to decide whether stroke is there or not. Okay. So it's just a very preliminary tools. Now, can you define stroke?
So, stroke is defined as a neurologic deficit which is caused by a focal injury to the central nervous system secondary to vascular disease.
Okay.
And it can include ischemic stroke, intracerebral hemorrhage, and subarachnoid hemorrhage, sir.
Okay. So here is the stroke definition. I just tell you. It's a WHO Monica project in 2002, I think. So basically, rapidly developing clinical signs of focal or global disturbance of cerebral function lasting more than 24 hours or leading to death with no apparent cause other than that of vascular origin. That is the WHO definition. And ischemic stroke defined as an episode of neurological dysfunction caused by focal, cerebral, spinal, or retinal infarction. It is the same WHO Monica project definition. Okay.
Okay, sir.
Now tell me what are the risk factors for ischemic stroke?
This can be classified into modifiable and non-modifiable risk factors, sir. So the non-modifiable risk factors include age, sex, females are having a high risk for ischemic stroke, family history, and certain hypercoagulable states like sickle cell disease, polycythemia, and Epler syndrome. And the modifiable risk factors include hypertension, diabetes, dyslipidemia, COPD, and peripheral vascular disease, sir.
Don't forget smoking and alcohol, huh?
Okay, sir. Okay.
Okay, these are one of the most common risk factors, which are the modifiable. So as you told, all the things, smoking, alcohol, obesity, hyperlipidemia, cardiovascular diseases, hypertension, type 2 diabetes, estrogen therapies, all are modifiable. Non-modifiable are definitely positive family history, prior history of stroke, and demographic factor, and sex. Male sex is definitely having a preponderance to having a stroke. So how will you localize the stroke?
Sir, I'm not very sure. The MCA stroke, which we commonly see, will be mostly presenting with hemiplegia of unilateral, contralateral side hemiplegia, and patient can present with slurring of speech also. I'm not, and the posterior circulation stroke, usually the patient will be having any balance issues and vision issues in posterior circulation stroke. I'm not very sure of anterior circulation stroke, sir.
Okay. So come to the basically ACA territory infarct always having a lower limb more than upper limb. Just remember, anterior cerebral artery infarct present with a contralateral hemiplegia with a more lower limb weakness and the motor loss than upper limb. There
Okay,
might be a presence of aphasia if the patient is having a left-sided lesion and with headache.
okay.
PCA territory infarct is contralateral hemiparesis, contralateral sensory loss, as you told, but there will be face and arm and limb almost same, homoanonymous hemianopia, ataxia, cortical bindless, and headache. In MCA territory infarct, upper limb weakness is much more than the lower limb. So there is contralateral hemiparesis, sensory loss, facial weakness, dysarthria, aphasia, gauge paresis towards the affected site, hemineglect, and headache. And as we come to the vertebrobasilar infarct, there will be ataxia, vertigo, dysphagia, visual field defect, headache, and vomiting.
Okay, sir.
Okay.
Okay,
Just
sir.
remember all those things. Basically, ACA infarct, more lower limb, MCA, more upper limb, PCA, more cortical bindless and everything. Vertebrobasilar also same only. More ataxia, vertigo. Okay, these are
Okay, sir.
all things you
Okay,
need to remember now. Now, what is the stroke timing and what is code stroke?
Okay, sir. So there are several timings, including door to physician time is within 10 minutes, door to stroke team time is within 15 minutes, door to CT initiation time is within 25 minutes, door to CT interpretation is within 45 minutes, door to drug time is within 60 minutes, and door to stroke unit admission is within 3 hours, sir.
Okay. So here is the NIMS trial we all know of.
Yes, sir.
Here is the time frame you have told us. So 10 minutes, 25 minutes, 45 minutes, and 1 hour.
Yes,
so
sir.
10 minutes, CT as primary assessment and CT8 should be ordered. Within 25 minutes, CT scan should be complete. Within 45 minutes, CT intervention should be done. And within 1 hour, if the patient is a candidate for thrombolysis, we should thrombolyze the patient. We should start the thrombolysis at least.
Yes,
Okay,
sir.
that's the time protocol. And from here only we got to know the time is brain the approach. Okay.
Yes, sir.
This is the code stroke activation protocol. So first responder, then there is a activate code stroke protocol 5327, it's US number, then a code stroke team, and then do not delay the CT and everything you know, the keep the blood pressure, establish an intracath of 18 to 20, then the CT to be done within 25 minutes, and then interpret it and start the thrombolysis if the patient is candidate for the stroke thrombolysis.
Okay, sir.
What are the severity scoring of stroke you know of?
We have NIHSS score. This is a clinical severity score and it consists of 11 variables and it will be scored from 1 to 42, sir. Based on this, we can classify stroke as minor stroke will be 1 to 4 and moderate stroke will be 5 to 50. Moderate to severe will be 16 to 20 and severe stroke will be more than 21 to 42, sir.
Okay, clear enough. You just, if you can able to remember all the components of the NIHS score, it will be good enough.
Okay,
Otherwise,
sir.
just remember the severity scoring.
Okay, sir.
Then what is the aspect score?
This is a CT severity scoring, sir. Aspect score, here the MCA territory will be divided into 10 zones, and for each of the zone involved in CT, 1 point will be subtracted from the aspect score. So if the aspect is less than or equal to 6, then it is having poor prognosis and the patient is more likely to go for hemorrhagic transformation, sir. Higher aspects is having a better prognosis.
Okay, okay. So now, what are the investigations of imaging investigation you will order for?
I'll order for CT with CT angiogram, sir, for this patient. After ruling out, definitely GRBS, sir.
Okay. In your institute also you do CT
Yes,
or
sir.
no?
In our institute, we follow CT angiogram protocol, sir.
Okay, okay. So we can do three things: NCCT brain, CT angio, and CT perfusion study.
Okay, sir.
These are the combined source improved detection of acute infarction when compared with NCCT alone. Okay.
Okay, sir.
So what we will find out in a CT brain?
There are some early, first of all, we need to rule out hemorrhage, sir. And we also need to look for early ischemic changes like loss of gray white matter differentiation, then dense MCA sign, insular ribbon sign, and lentiform obscuration, sir.
Okay. So what is basically dense MCA sign and MCA dot sign? What is insular ribbon sign? What is cortical ribbon sign?
Dense MCA sign means we will be able to see hyper intense dot in the MCA area and it indicates a fresh thrombus.
Okay. So basically, I'll start from the ribbon sign. So basically, there will be the loss of gray and white differentiation in the basal ganglia nucleus. If you see, there is a lenticular obscuration. So we
Okay.
call it a insular ribbon sign. If it's present over the convex cities, it will called as a cortical ribbon sign. And there will be the swelling of the guide eye that cause the sulcal effacement, and that is also called cerebral ischemia.
Okay, sir.
So, though the faster these signs appear, the higher degree of ischemia, of course. Okay. And
Okay.
a large vessel occlusion can be seen as an increased density within the occluded artery. If the whole artery is occluded, that is called dense MCA sign. And if there is a dot, it is MCA dot sign. Of course, MCA dot have a better prognosis than dense MCA sign because the less thrombus load is there. So
Okay.
why CT brain is the primary imaging of choice?
First is that CT will take lesser time compared to MRI, and in a patient who is typically presenting with clinical symptoms of ischemic stroke within 4.5 hours, our primary aim is to rule out bleed. So if there is no bleed, we can go ahead with thrombolizing this patient if the patient is within the window period, sir. But if the patient comes out of the window period, then definitely diffusion flare mismatch and MRI will come into role, sir.
Okay. So basically, why CT brain? Differentiating ischemia from hemorrhage, as you have told. Then it can exclude the stroke mimic also. Just you have said space occupying lesion. Then assessing the status of the large cervical and intracranial artery.
Okay.
And then estimating the volume of brain tissue that is irreversibly infected. Infarction code, we can get if you do a CT perfusion, and estimating the extent of potentially salvageable brain tissue that is at risk of infarction, that is penumbra.
Yes.
Okay.
Okay.
And as we said, aspects, we all discuss about aspect. Just remember, there is a multicentric study Aviv et al. Have done in 2007 and found out if there is a aspect score is less than 8, treated with thrombolysis, their 3-month clinical outcome is not good. So mortality was higher, morbidity is even higher. So less than 8 treated with thrombolysis is not a very having a very good clinical outcome. Huh?
Okay, sir.
Then come to MRI brain. You are telling, now tell me, what are the sequence you will look for in the MRI brain? And when you will ask for MRI brain. So I think many of the institute do follow MRI stroke protocol also.
Yes, there are institutes which follow MRI also, sir.
Yes.
So, if the patient is within the window period and we are ordering MRI, we can order for just MRI screening to look for diffusion, flare, mismatch, and basic cuts only. But if we are planning, but if the patient presents like a wake up stroke and the time of onset is unknown, in this case also we definitely have to look into diffusion flare mismatch, and the other cuts which we order in MRI brain include T1, T2 weighted image, and GRE, and these are the views that we look into, sir.
So MRI brain, as you said, the gradient echo sequence is equivalent to CT. And now diffusion weighted images are the most sensitive and specific imaging technique for diagnosis of acute infarct. Okay. And with that, with the diffusion weighted image with ADC, you can find out whether it's an acute one, subacute one, hyperacute one, or the chronic one. Okay. And with that, also, we can differentiate between cytotoxic and vasogenic edema also.
Okay, sir. Okay.
So these are the protocol we'll follow: T1, T2, flare, diffusion weighted image, and ADC. Okay.
Okay.
So here is a pictorial diagram how you will see the acute stroke in timely manner. So hyperacute, in fact, in T2 flare, it will say as normal. In diffusion weighted image, it will hyperintense, and ADC hypointense. As the time goes by, there will be the reduced diffusion and cortical T2 hyperintensity, and with the increasing mass effect. So T2 will look more hyperintense as the time passes by, starting from 6 to 72 hours, then early subacute, then late subacute, and diffusion DWI images will look more hypointense slowly over the time, and in chronic infarct it will be isointense, and in chronic infarct T2 will be diffusely hyperintense, and ADC it starts from the hypointense, slowly it will be hyperintense in the chronic infarct. Just to remember the whole MRI sequence, that's it.
Okay, sir.
Sir, you want to add something up till this time? Hello?
I am noting down. I'll talk at the end. It is better. I will not stop the flow. She's
Sure,
answering
sure.
wonderfully well.
Sure,
So
sure,
she's
sure,
almost
sir.
giving perfect answers, to be honest.
Sure, yeah, yes, sir.
So I won't stop the flow. Yeah.
Okay, sir. So now, what are the advantages of MRI? You are known of.
Yes, we can rule out the other stroke mimics also, which may not be seen in a CT. Like if there is any space occupying lesions, and we can also rule out meningitis, encephalitis, and any posterior reversible encephalopathy syndrome, hypertensive encephalopathy. All this can be ruled out with MRI, sir.
And what are the limitations?
Limitation is definitely the time, and some majority of the centers may not be having MRI, so to shift to another center for doing this might take time, and it might time is important here, sir.
Sure. Okay. And what are the advantage of CT scan over MRI?
One is definitely the time. It takes the least time, and also we can rule out hemorrhage, which is a priority in an acute ischemic stroke case, sir, before thrombolysis.
Okay. So advantages of MRI, as you told, diffusion weighted images are highly sensitive. There's ability to distinguish between acute small cortical, small deep, and posterior fossa infarcts. Acute from chronic ischemia, you can distinguish, as I have told. You can identify subclinical satellite lesions, and ionizing radiation you can avoid, and greater spatial resolution. And GRE sequence is as good as CT to detect intraparenchymal bleed. These are the advantages you should note for.
Okay.
Then the limitations of MRI, definitely cost, relatively limited availability, you have told, long duration, increased vulnerability to motion artifact. But please tell these contraindication: claustrophobia, cardiac pacemaker, patient confusion, and metal implants. You might not get a patient with a cardiac pacemaker with unknown MRI status. Maybe it's not MRI compatible. So don't take chances in those cases. if you are not sure about. Okay,
Okay.
so
Okay.
please note it down. And
Okay.
then advantage of the CT scan over MRI, of course, detection of bleeding is the main priority, less time consuming, less cost, widespread availability, and less artifact because it's less time consuming. So, what are the other investigation you will order and
Um,
why?
So the only indication that I'll look before thrombolysis would be GRBS only, blood sugar only. But we can definitely go ahead with ECG, troponin I. But all this should not delay thrombolysis in a patient. So if the so once the emergency routine everything is done, I'll order for other routine blood investigations like CBC and troponin I, ECG. And if the patient is already having any lung issues, I'll order for chest X-ray and to look for his baseline renal function test. I look for RFT, and these are the baseline investigations that I would like to have, sir.
So with that, I just want to add the coagulation profile,
Yes, sir. Okay. Yes,
PTFET, of
yes, sir.
course, and a carotid Doppler to see the carotid vessels and a 2D echocardiography.
Okay, sir.
In selected patients, thrombin time and recurrent clotting time, you can ask for if a patient is already on factor 10A inhibitors and
Okay.
hepatic function tests and toxicology screen. As I told now, it can be from psychiatric drug overdose also. So
Okay,
you
sir.
look for if there is any toxicology screen and if there is a chance of blood alcohol consumption, then blood alcohol level pregnancy test, and do a arterial blood gas if hypoxia is suspected, and lumbar puncture if there is a suspicion of subarachnoid hemorrhage or the meningitis, and if there is seizure, then EEG.
Okay, sir.
So what are the initial management you will start?
So I'll definitely start from ABC itself, sir. This patient, he's having a GCS of 14/15, but his airway is patent. So I'll try to target a saturation of 94% for this patient. If it is more than or equal to 94%, that is okay. If it is less than that, I'll initiate the patient on oxygen. Then BP targets, we definitely have targets for each stage, sir. Like if we are not planning to thrombolyze,
Will come later. Okay, that.
okay, okay, sir.
So what would be the primary goal of the initial management? So of course, airway breathing circulation you will secure. Then preventing further neurological injury,
Yes, sir.
determining the optimal modality for reperfusion.
Yes, sir.
That's the primary three things we'll look for. And here is the ICU admission criteria. You'll just remember or gulp it, altered sensorium, brainstem dysfunction, respiratory dysfunction, severe brady or tachyarrhythmia, hypotension, raised ICP with high risk lesion, basilar, large hemispheric infarction. So you'll in those cases we'll admit under a stroke unit or the ICU.
Okay, sir.
So what are the intravenous thrombolysis agent you will start and what are their dose and everything? It's safe. Tell me, how will you proceed for intravenous thrombolysis?
Okay, sir. So we have two agents, alteplase and tenecteplase. The one which is commonly used in our institution is tenecteplase at a bolus dose of 0.25 milligram per kilogram, sir. And the other agent is alteplase, which is given at a dose of 0.9 milligram per kilogram of maximum 90 milligram, of which 10% of the dose will be given as a bolus over 1 minute, and the remaining will be given over 60 minutes, sir.
Okay. So your institute, you have already told us that
Tenecteplase.
is used.
Yes, sir.
Is it universally recommended or what are the studies you can
The
take?
recent ACC-AHA 2019 guidelines recommend the use of, it also mentions the use of tenecteplase, but there is no superiority which has been shown between the two agents. There was one trial called Extend 1A TNK trial, and it was shown that tenecteplase is non-inferior to alteplase in that study.
Okay. So basically, three studies is there. In 2018,